Hello, thank you for having me. I want to thank Dr. Christian for putting on such a great conference here. So we're going to talk a little bit about wound care basics today. I have no relevant financial relationships to disclose. So the importance of this topic really is that diabetes has been the greatest contributor of non-traumatic lower extremity amputations, and diabetic foot ulcers continue to be the primary reason for hospitalization for these diabetics. As we know, diabetes leads to increase in amputations, reduced quality of life, and enormous financial burden to both the community and the individual as well. And we understand now that the global prevalence is increasing, and it's now at almost 6.5%. Something to keep in mind is the end stage of these diabetic foot ulcers is of course amputation, which we're all trying to avoid. And these amputation events are not without their risks and consequences. About 7 to 22% of patients that undergo a major amputation will die within 30 days, and the 5-year mortality is between 50 and 80%. So these amputations are really a death sentence in some ways. And even more important than that is more than 50% of the patients that receive this type of amputation will become permanently disabled and never return to ambulatory status. So it's really a dire situation to try to salvage as much as possible. So what is the pathway to these ulcerations, and how do we prevent it is very important. And there's a critical triad of symptoms that can happen here of neuropathy, deformity, and trauma that account for approximately 63% of the wounds that are seen, with neuropathy being the main player at 78%. And what this tells us is that 80% of these ulcers are preventable through either offloading the area or common podiatric visits where you can kind of see these pre-ulcerative lesions developing and try to take, some offloading steps to kind of prevent these as they go on. And even ischemia only accounts for about 35% of these ulcers. So it's important to keep this in mind. So what are the goals of wound care? And we have here, keep it simple, because none of these things can work if the patient doesn't want to do it. So that's the most important thing. If the patient can't tolerate a dressing, it could be the best dressing in the world, but if they take it off, it's useless. So we're going to go through these individually, but most important, remove non-viable tissue either through debridement or wet-to-dry dressings. You want to achieve moisture balance, through your dressings. You want to offload the area and detect and manage vascular disease, which we're going to kind of get into. Treat underlying infection if it's there, and of course medical management, controlling for glycemic control, as well as smoking cessation, things of that nature. So when you see a wound come in, we want to make sure to do a proper assessment. Take a look at the diameter, which will become a major endpoint for us as far as lessening the size of the wound. Your depth, your drainage, which will help determine the type of dressing you're going to put on the wound. Your wound edge characteristics, the odor, the edema, the vascularity. And vascularity here is a very important thing, and we're going to talk about the International Working Group Diabetic Foot Guidelines here coming up. And these are important because it actually says that there's no clinical signs or symptoms that can accurately exclude PAD. And ABI is the most common test to diagnose to screen for PAD. However, it's not effective to rule out PAD in patients that have neuropathy, and many of the patients that have neuropathy will be the ones to develop these ulcers. So it's not enough just to get an ABI or to say, oh, okay, I feel the pulses, the patient doesn't have PAD. It's really important to keep your clinical suspicion high, and the guidelines here tell us that even if you have a normal ABI, if you're suspicious, you should really send it out and to be very diligent to avoid the negative outcomes we saw previously. So one of the classifications that I think is very important, this was touched on earlier by Dr. Singla, is the Wi-Fi classification which looks at wound ischemia and foot infection. This is kind of modeled off of the tumor, node, and metastasis model. And what's important about this is you can actually see there's 64 categories here, and these green, yellow, and orange boxes are telling us what the risk is of amputation at 1 year if a patient comes in. So just by you taking the time to classify the wound when you see it initially, you can actually give the patient an idea of what their risk is at 1 year of losing the limb. And this is a paper out of Journal of Vascular Surgery, just showing the effectiveness of the Wi-Fi classification system to predict 1 year outcomes, restenosis amputation events, and wound healing in patients with CLI undergoing endovascular procedures. So we talked about this before, and it's important to re-mention it. It's the International Working Group of Diabetic Foot Guidelines, and we're going to go over a lot of them today. And one of the most important is to remove slough, necrotic tissue surrounding the callus of the diabetic foot ulcer with sharp debridement. Although you want to keep in mind some relative contraindications like ischemia, for example. You don't want to use sharp instruments on a patient who may not heal. Again, we talked about this a little bit. The International Working Group recommends that the dressings are really to achieve moisture balance. So if you have a wet wound, you want to make it dry. If you have a dry wound, you want to make it wet. Relatively simple. So moisture balance, there's all kinds of fancy different dressings you can put on here. If it's too dry, add moisture, like we said, hydrogels, hydrocolloids, and if it's too wet, you want to have hydrofibers, alginates, super absorbent type of dressings to kind of mitigate that. And how do they look? Characteristics of a wound that's too dry. You can see the eschar here on the hallux. If you're taking the dressing off and you notice that it's sticking to the wound, that's a safe assumption that that wound is too dry. So you want to soak that dressing off. This way it does not cause any trauma when you remove it. Also consider debridement when you see an eschar, especially if the patient has circulatory status that's sufficient to manage that, just to see if there's any infection underlying. So what are the characteristics of a wound that's too wet? Hypopigmentation, hypergranulation tissue, excess exudate, you're changing the dressing multiple times per day. And again, we kind of talked about the superabsorbents, dressings to kind of mitigate that. And what about offloading? So this is another guideline given by the International Working Group on how to offload properly these ulcers. And what's very important is you'll see from left to right, and then from left to right, and then on the bottom of the page here, first we see essentially a makeshift total contact cast with the boot there that's non-removable. So if you have no infection and no ischemia present, the recommendation is to use a non-removable knee-high offloading device. If the patient doesn't tolerate that, consider using a removable device. If the patient doesn't tolerate that, let's use an ankle-high. And if they don't tolerate that, let's use a foam cutout. Many times the foam cutout is often the first or the preferred treatment just because it's easy, it's cheap, and it's fast. The guidelines are to start out with the non-removable boot in order to try to help prevent these ulcers from going forward. Next is you can also surgically offload these ulcerations. If you have a forefoot ulcer, you might want to consider an Achilles lengthening type of procedure to take some of the pressure off of the forefoot. And if you have a digital ulceration, maybe a flexor tenotomy, it can be recommended to kind of decrease the pressure on the digits. So what about oxygen therapy? And these are important guidelines that we're going to go over, especially because these are some of the newer techniques that are coming out, and a lot of controversy on when and who and how. So first we're going to talk about what the indications are, and the international guidelines are that we should consider hyperbaric oxygen therapy as an adjunctive treatment to non-healing ischemic diabetic foot ulcers, even despite the best standard of care. And for topical oxygen, the recommendation is to not use topical oxygen therapy as a primary or adjunctive intervention for diabetic foot ulcers, including those that are not healing. And we'll kind of go over the data for where these guidelines came from. So this schematic that we're seeing here is actually from 2003, showing the early results of hyperbaric oxygen chamber versus placebo. And as you can see with the dark columns here, hyperbaric oxygen was really outperforming placebo very well, and so as far as healing these ulcers. And this is kind of how this came to be so popular. But as we can see in Diabetes Care 2016, and on the next slide, 2018, HBO was not offering additional advantage to comprehensive wound care in reducing the indication for amputation or facilitating wound healing in patients with chronic DFUs. And you can see this here on the next slide right here, where there's really no difference between HBO and standard of care. So currently the recommendation is to still use hyperbaric oxygen therapy for these non-healing wounds, but obviously more data is going to come from this, and we'll see if it really is effective or not. And similarly for topical oxygen, the evidence is conflicting. So earlier studies had shown a higher proportion of wounds that were treated with topical oxygen to do better than placebo and faster time to closure. However, some of the newer studies are showing no real difference between topical oxygen and also, compared to your standard of care debridement. So what about negative pressure therapy, the wound vac? This came out as a real game changer. And the indication right now is to consider the use of negative pressure to reduce the wound size in addition to best standard of care in patients that are post-operative. So for example, if you do an amputation and you have a large defect, the use of negative pressure wound therapy has been shown to increase high granulation tissue, reduce the size of the wound, and has been shown also to reduce secondary amputation. So it's really something that we want to consider and use as often as we can. However, the guideline for non-surgical or chronic foot ulcers is that the negative pressure wound therapy really did not have too much improvement there, even though the data does suggest that, and we'll kind of go through this too. So post-surgical wounds, like we talked about, reduce secondary amputations. It has also increased granulation time, and it also has reduced the length to wound healing. And for the non-surgical wounds, the data has shown that it's been effective. However, there's been a lot of dropout in these patients, but I think largely because, and it says in some of the articles here, that the patients are not tolerating this vac. It's like a bag they have to carry around. It comes off. It's very frustrating for the patients. So maybe for the patients that have had a prior amputation, they're considering, and maybe they're taking it more seriously. They want to use it as much as possible. For the ones that have had a chronic ulcer, maybe they think they're not worried too much about the ulcer. It's been there for a while. They don't want to use this vacuum as much as they probably should. And what about placental-derived products? There's not a ton of data out there on this, but the guidelines are that the placental-derived products are very effective and should be used when standard of care products have not worked. And you can see some data at the University of Texas with Dr. Lavery showing that placental-derived products, in this case graphics, almost twice as effective of closing the wounds as your standard of care treatment. Okay, and for platelet-rich plasma, PRP, I mean, they're using this for everything from knees and ankles to now wound care. And as you can see, this meta-analysis shows it very clearly that it does help. As you can see in the graphs pretty clearly, the left side of the screen is showing favors PRP as far as wound healing. And you can see it across the board, it outperforms your standard of care or the control treatment here. So PRP is something we might want to consider doing for these wounds that are not healing. And future pathways include, combination growth factors, targeted protease inhibitors, enhanced cytokine production via viral therapy, stem cell therapies, enhanced matrix modalities. I mean, I think until we kind of get a handle on how to heal these wounds in an effective, fast way, the research will continue, and we'll see, how to go about that. So, thank you for your attention.